Hi, good afternoon or evening. I am Karen Moss. The first time I came to Iowa City, it was 23 years ago, with my baby boy, looking for answers from Dr. Ponseti, who I'd spoken to briefly on the phone, and also spoke to Martin on mail. So a lot has happened in those 23 years. Where's the... Will you help me with the technology? Okay, thanks. Next slide. Thank you. So I started STEPS in 2005. It's 21 years old this year. And our mission was to increase access to clubfoot care for children using the Ponseti method, which at that stage did not exist in South Africa. And having then had our first Ponseti training in 2006 and the consensus from doctors that they would shift from surgery, and I did this all on request of Dr. Ponseti himself, because I asked him why, if he'd published his study in 1963. In 2003 I had to fly to Iowa, and why wasn't it available in my country? So I started STEPS, and our mission, as I said, was the access to treatment for children that was effective. And we eventually developed a 4-pillar model of support working in government and doctors. So our model is 3 parts. It's the government, which provides indirectly, because we had what we call really a bottom-up approach, because if we'd waited for our Department of Health to say, yes, you can do the Ponseti method, first of all, the doctors were the ones that would advise on their recommended practice for clubfoot, not the government. And secondly, it would take many years. So the government provides clinic infrastructure, staff, consumables like casting materials and that type of thing, and by government law we have free treatment for children up to the age of 6. Then the second part is SAPOS, the South African Pediatric Orthopedic Society, and they provide Ponseti expertise, training, mentorship and medical oversight of everything we do, and obviously everything other people do, orthopedic surgeons, and that goes down to affiliated health professionals who may assist with casting and other parts of the treatment. And STEPS is a non-profit organization. We essentially just on our feet all the time trying to fill in the gaps, because we have a very under-resourced health system. So we provide our 4-pillar model, which is very patient-focused and family-focused, education materials for families. We brace supply, clinic coordination, tools, advocacy, Ponseti training, you name it. When there's a need, we find a way to fix it. So I was thinking about our data, and I realized that we had a similar approach, because in South Africa we tried to take something that worked really well in North America, but to deal with the realities on the ground, the economic issues that affected children accessing treatment, the lack of South Africa's massive geographically, people don't have money to get transport. There are various areas, and we addressed all of those by providing things like clinic coordination, having staff in the clinics working for STEPS, advising parents, all that type of thing, and gradually providing things that would address those gaps. And so we built, well, stigma, is a very big thing, as we discussed earlier, awareness campaigns. So every gap we could find, we did. And the same thing happened for data, because we have what's called the POPI Act, Protection of Personal Information Act. And we found that anything that we tried to use for data could not be used in South Africa, anything international, for various reasons. And we also wanted something that would deal with connectivity issues, because most of our clinics didn't have internet access, and something that would be configurable and clinic-owned and driven. So just a little bit of background and context about South Africa. There's about 2,000 cases a year. We don't know really, because we still don't have clear data right across the country. But it's just based on that, it's 5 or 6 children a day being born with clubfoot in South Africa. And we don't have any birth defect surveillance of any birth condition whatsoever in South Africa. They've tried to bring it into the country through the Department of Health, and all of them have been failures. I think the last study published in 2017 was a 3% uptake in clinics of monitoring of birth defects. So, this is the 10-year process of what we did to try and find data in the clinics, and how could we do it. So we started with paper and Excel, and it was obviously not very efficient, especially in a clinic, for example, Baragwanath Hospital sees 80 to 90 patients in a morning. And so what we found is the Excel spreadsheet was sitting there and nothing was really happening with them. And then we looked at other things like the other things that were available, you know, for example, the Iowa Clubfoot Registry, Salesforce, but all of them were vetoed by the doctors because of our Protection of Personal Information Act, because they all required patient information details, so we were barred from using those. So we kind of went along for about 5 years, it was 3 years, not really achieving much in terms of data. It was very disappointing. And then in 2019, two things happened. The doctors had a meeting which I attended where they decided to try and use RedCap to collect their clinical information, which we do at some of the clinics. And at the same time, my data person who worked at STEPS suggested that we look at Google. I didn't know anything about Google, but it did work because we found that it was very easy to configure, cheap, free for non-profits, and it also dealt with our confidentiality issues because it was only statistics. We weren't collecting patient information because we're a non-profit. We don't need clinical details. We just want impact and stats. And eventually we started, by the time we got to 23, it was like a 5-year period or 4-year period of getting that right. But we still didn't have a lot of uptake from our clinics until about 2019. And then we brought in our reward system. So everyone who submitted weekly on time either got a coffee voucher or airtime. And that upped it quite a bit. Then we thought, in 23, 24, we thought, but how come, why are we expecting these people to give us everything from the clinics, but we're not giving them anything back? So we started to develop through Google a sheet that they would get every month that would give them a snapshot of all the clinic statistics. That improved the uptake a lot because they were getting something they could see worked for their clinic. I don't think I need to go into that a lot with this slide because I've already spoken about most of this, but I think if there's anything that I know, I think everything's covered already, so let's go to the next one. But really what it shows here is how we carried on using Google, and now we're in a rollout phase of using the Google App Sheet and Google Looker Studio, which is real-time data, like a dashboard that you can look at any period. Only that clinic can look at their own data, whoever's been assigned that, and it's an amazing tool. Right now it's working in, I think, 6 clinics, and we're still doing the rollout to the rest of the clinics, 48 clinics in total. So here's the growth in our partner clinics. We started off with 6, now got 48. So you can see how we had to collect data in from a number of clinics weekly. We had to get a system that was simple and efficient. And then this is the growth per year from 2017. You can see the drop in 2020 because of COVID, and obviously it's grown a lot. That's one example from the live dashboard. It's comparing 2 hospitals, Chris Hani Baragwanath and Charlotte Matseke Hospital. Chris Hani collects recurrences because they're the biggest clinic in South Africa and they tend to get most of the recurrences. So we can customize if the clinic wants to add an extra statistic. That's our indicators for last year. We recorded almost 20,000 clinic visits. 1,300 children were enrolled, and there's over 5,000 kids at one or other stage of treatment. We also collect gender and bilateral, unilateral. So the conclusions are that data can be effectively done at a very low cost in LMICs. It has several advantages where there's national treatment visibility by town, province, region that we can customize as we want to look at it. It's also, we can plan resources, either us or the clinic partners. We're improving quality. We now have an 83% submission weekly. We are aiming for 100. We're also doing research collaboration, not only with the University of Iowa and Stellenbosch, but also University of Cape Town Health Economics, and SAPOS members have used the data for their studies. And the next steps are we want to try and see if this system can work, or the concept of it, to bring more both data surveillance into our country. And that's the end of my talk. Thank you.